So I think, specifically what, Emily asked me to talk about today, and I want to make sure I go through with enough time for questions at the end, is the treatment, right? So if you go back to 1994, the main treatments for PFIC was, there was no really any definitive therapies. We talk about supportive measures. And so these are improving things like nutritional deficiencies and managing the complications of their progressive disease. Well, if you skip, ahead a couple decades to 2020, unfortunately, as I think many in this audience know very well, very little has changed in that. We do have some additional surgical options, mainly diversion, and I'll let my colleague, Dr. Soltis, talk about that in the next talk. But as far as pharmacological therapies, we really have made very little progress in kind of combating PFIC. But there is still the future, and I think we will definitely end this talk hitting up some of the ways in which we hope in the future to be able to change this slide, so that when I give this talk next year, we'll be able to have a little bit more information about how we can treat these diseases. But I think it's important to kind of look at some of those historical measures that we take and those supportive measures that we take, and talk a little bit about why we do that and how it affects the specific PFIC disorders. So first, again, improving nutritional deficiencies, right? So this is your typical growth curve of a child, and this is the kind of the way that a child with PFIC often tracks. They are often small and often struggle to gain weight appropriately. So if you ask why is it that children with PFIC have difficulty gaining weight? This is where we get into the importance of bile and really the importance of bile acids. And so this is a picture that I think many probably have seen similar pictures before, and we will come back to later in the talk, but goes over kind of, where bile salts come from, right? And they mainly come from, cholesterol and the breakdown of cholesterol. That forms bile salts, which then are excreted out of the liver into the intestine, where they act as emulsifiers. And we'll talk about how they work from that standpoint. They then travel through the GI tract, most of which are reabsorbed in this at this terminal ileum, this end of the small intestine, and then kind of recirculate through the body in the intrahepatic circulation. So again, if you think about the functions of bile salts, bile salts essentially act as detergents to help break down fats. That's why they work. I think we've all had that experiment back in grade school, high school, where you take oil, you mix it with water, and they separate out because they don't mix very well. So as we eat fats and are trying to absorb those fats across the membranes of our cells, which are mostly water, you really need a detergent or an emulsifier to break down those fats into a size that we can then get across the cellular membrane. And so that's what bile acids essentially do. Bile, they get into the small intestine after being secreted from the liver. They interact with these large fat droplets and emulsify it and break them down into much smaller particles that are then able to be absorbed across the enterocyte, or the cell that lines the GI tract. And so you can imagine, if you don't have bile salts, or you don't have that ability to break down fats very well, you can't absorb fats. Fats are critical for nutritional development and for growth. And so for children with any cholestatic disease, this is obviously not unique to PFIC, but with any cholestatic disease, children aren't able to grow and gain weight very well. So again, just a picture showing that when, in the PFIC disorders and other cholestatic diseases, if you block those bile acids from getting out of the liver and into the intestine, you aren't able to gain weight very well. And so again, the sequelae of this is fat malabsorption and failure to thrive.